So I'll just give a head nod first to some of the collaborators in this work. Andrew Smith and Janet Wiles are colleagues of mine at the University of Queensland in the School of ITEE and also with the Institute for Social Science Research. Andrew is the inventor of Lexomancer, which is another popular content analysis tool that I think some of you may have used or at least heard about before. This work that I'm going to present today on Discursis was really the work from about, I guess, 4 years of us working together as a team to really kind of get a sense of how do you unpack the temporal dynamics of communication. Now, Bernadette Watson and Cindy Galwer are colleagues also at UQ, but they're in the social sciences areas. So Bernadette is an expert in doctor-patient communication, particularly handovers and medical handovers, and Cindy Galwer is a luminary in the field of conversation accommodation theory and also has a strong interest in doctor-patient communication. So the work I'm presenting has actually been published in PLOS One, so I'll give the reference at the end if anyone wants to read a bit more about it and also the technique. I think it's a good paper to understand discursus as a visualisation approach because it places it in a context that people are maybe familiar with, which is doctor-patient communication. So let's just start out by defining a few little things and giving you a picture of what it is we're trying to achieve with this particular software and visualisation tool. So we think about these things as conceptual events. We think about a conversation as a series of conceptual events that are happening between multiple speakers. So in this case here, I've taken just a little bit of text from a television show in Australia called Insight. The host is Jenny Brockie, and in this particular instance, just these two brief utterances between a member of the audience, Susan Candlish, and Jenny Brockie. And so Susan's explaining her son had appendicitis and was going to the hospital, and this whole episode, I was actually in the audience for the episode, so it's a bit kind of the Inception-ish, right, me doing an analysis of a text that I was kind of part of. But it was interesting because for this particular one here, what I've done is just highlighted the major concepts that are being discussed by Susan Candlish and also by Jenny Brockie. So you can see Susan Candlish is mentioning things like appendix and surgeon and operation and discomfort and uncomfortable, and you begin to get this kind of rich picture of some of the semantic content of that turn in this particular exchange. And then Jenny Brockie comes back to kind of get some more reiteration around the appendix had burst, right? She wants a clarification to get and steer Susan Candlish to talk around this particular issue in a little bit more detail. So if we think about this as and all the concepts that are being discussed during this exchange as a two-dimensional landscape, where what we do is we place all the major concepts as landmarks. So like you might have buildings on a university campus like we're at the moment, what you can think of is a conversation is a journey around that particular landscape. So at time point 2, so this actual exchange that I've reproduced, this was very, very early in the show. So Jenny Brockie started off with a question to Susan Candlish, who then was engaged with for the first half of this show. So that was her exchange there. She was talking about the surgeon and appendix and such. Jenny Brockie is probably more close to appendix because she's asking, oh, the appendix had burst. So that's the kind of conceptual building that she's located next to. And then we get a sense that, well, in the follow-up question, Susan Candlish is going to move in this space to some other location. And if we actually track these two speakers over the length of the conversation, you can imagine them walking and wandering around this particular landscape that we've created. So if we try and flatten that view rather than having it 3D and place all the concepts out like this and have our two actors interacting, in this case it's they're green and orange, you get this kind of view. And we've seen something like this with what Anne presented yesterday, with the values going for the F1, F2 values moving around. We did this and we tried this on a few different conversations, but what we lost in this particular visualization here was a sense of, okay, you can see them coming together and meeting in this particular area of this map. And that might indicate that they're actually engaging around the same content. But are they occupying that same space at the same time? Right? It's hard in this visualization to track, is this, you know, the second, third, fourth exchange in this particular conversation? You really, I mean, unless you start here and try and follow it all the way along, it's hard to pick out some of that temporality from that particular static graph. So we looked to dynamic systems. And when we looked to dynamic systems, we found this particular approach. And I mean, this exists in a lot of literature. You find, I mean, I've seen some of these plots already at this conference. People might call them adjacency matrices, co-occurrence plots, all kinds of things. With recurrence plots, they're slightly different to just plotting a straight difference. What they're actually doing in this case, and this is weather data here, and this is human ECG recordings, is they're not just using 2 points and looking for how similar they are. They're actually looking at the phase as well. So it's not just about occupying the same space, it's about occupying the same space by coming in the same direction to that location. So if you think about it, you know, I can enter this room from the front door there or the back door there. Right? So there's 2 entrances to arrive in the same location. And so that might be important, is how you actually transition to the point that you occupy. And so that's what recurrence plots bring to this. And so these are just a couple to give you an idea about the technique, and I'll show you how we used it with Discursis. So what we did, the first thing we did was flip the plot. So we flipped the plot, so in the previous example, you have a sense that time is running up the diagonal here. In our plots, we actually flip it so time runs down the diagonal instead. And then what we do is we place all of the text, these exchanges. So these are the first 2 that I'd shown in that first slide. So this was the piece of speech by Susan Candlish, and the second one by Jenny Brocky, the host. And then we place the entire exchange down this way. What we then try to do is try and link multiple utterances and how they actually share conceptual content. So if we see a shading here, it means that those 2 connected utterances, so this one here and this one here, share some conceptual content. In this case, it's about the appendix. If you see a blue square like that, it means that, in this case, Susan Candlish has repeated her own concepts. So this is how we colorise this plot, and you can use it for any number of speakers that you like, and by just adding extra colours into the plot. I mean, obviously at some point it's going to break down. If you have 500 speakers in your data, you're going to start to run out of colours and to be able to work out the difference between it. To get around this, we actually allow people to group speakers into groupings. So if you had, you know, say 2 political parties in a debate, and there might be, you know, 100 on one side and 100 on the other, you might group them into their respective parties and analyse it that way, and so you can restrict the number of colours. So yeah, and you run this down the diagonal and you start to see structure. So we start to see these little blocks and all kinds of other patterns that emerge. So for one of the first case studies that we did, we engaged our colleagues in social science and health communication to start looking at doctor-patient communication, because it's an area which is very well studied. There's a lot of pre-existing analysis of existing conversations, and we thought this is a really useful way to validate the tool and work out, is it showing us interesting patterns, is it useful, what can this visualization be used to do and to tell. So for doctor-patient communication, we know that poor communication in a health context leads to poor patient outcomes. There's a lot of literature out there that talks about the importance of communication in the health context. I'm sure you all know with your doctors, you know, when you go to see them, if you have good communication, you tend to get a better experience. And also, I mean, most importantly, effective communication in a health context is related to adherence to the actual diagnosis. So it's not just about the doctor getting the information and it being one-sided as an information sink. It's about the doctor being able to communicate to the patient and say, all right, you have such and such a disease, you need to take this medication or get this follow-up test. And if the patient doesn't understand what's being asked of them, they're going to have poor enlistment. they'll take the wrong dosage, or they won't get the follow-up test. So that's part of the importance of this. And there has been a shift. I mean, in the last decade, particularly in Australia, there's been a shift from a focus on just the health professional's role in this to more about that of the patient's communication. And we actually posited that early that it's actually about understanding both the roles, both the doctor and the patient, and understanding both in the interaction between them is what's most important. So particular patterns that we're looking for are things like joint engagement around issues, how the patient can elicit their concerns early in a consultation. Getting the patient to talk early is a really, really important thing in a health context. If the doctor steers the conversation too early, they might not enable the patient to actually elicit their concerns, and so they'll be essentially putting words in the mouth of the patient rather than getting the full information that they need to arrive at an accurate diagnosis. So these are good predictors of patient satisfaction as well. If a patient feels they've been heard, they'll walk away as satisfied, versus someone who is talked down to or doesn't feel like their doctor has actually heard their concerns. So our methodology for the study was essentially to determine if discursus could be used to understand and unpack and reveal these dynamics, these doctor-patient interaction dynamics. And if we could do that, if we could find interesting patterns, could we then identify particular patterns which relate to good and poor outcomes? So we had data around patients visiting their doctors and giving a survey at the end as how they felt the exchange went. Right? So we had a sense of what was good and what was poor, and so with that kind of that evaluation, we could then use discursus and in an informed way try and figure out, well, if we see these particular patterns, they may indicate that this is a good communication pattern, and in that sense validate the methodology at the same time that it is able to reveal interesting things that are going on. So for discursus, I mean, we set up a few analysis tasks going into this. We wanted to be able to see global structure. It's one thing we found, and I looked at some of the transcripts just as text on a page. What I found was it was hard to actually get a sense of the global structure. Right? You could read through the transcript, but it was hard to kind of keep. I mean, some of these transcripts can go over 10 separate A4 pages if you print them out. And so it's very hard to hold that information in your head and remember, oh, they mentioned this particular concept much, much early on. I'm going to go back and find that. So it's hard to get a sense in just a plain text transcript of what's going on and what the global structure is. It's also hard to identify critical time points. This is one thing we're really interested in, is are there time points where things go right or wrong? And where are these time points located within the communication? And then can we divide the conversation and the communication into regions of interest? So can we do some kind of automatic paragraphing of a conversation using the visualisation to direct attention to allow some other informed analysis? So we're not saying that you just use discursus and that's it and come to your conclusions. It's more about using the visualisation to direct attention so you can bring much more powerful analytical methods to bear, but bring them to bear on various sections of interest. So rather than having to labour through 10 pages of transcript, and you might have 100 of these particular transcripts, it can actually hone down to one area of interest to save the analyst time. So, as you said, you've got the diagonal, which represents time running down. In this case, the patient's in red and the doctor's in blue. What's really interesting is just before we even block out the off diagonal here, you get a sense by placing it end to end like this of who's talking when. So the size of the square represents how much text there is there. For this particular transcript data, we didn't have onset and offset information, so we don't have white space for pauses or anything like that. We just have a sense of who spoke in what order, and we enforce an ordering. So if two people are speaking at the same time, they have to actually split into an order. So there's no overlaps in that sense. And just the amount of text in a turn is the way we use to code the size of that utterance. If we did have information on utterance, onset and offset, we could use that in the visualisation. So this is our patient, and in this case here, this is training data that was presented to us by Queensland Health. our colleagues there had spent a lot of time working out and figuring out this whole bunch of this training corpora to use with their medical students. And so they had what were a whole diverse array of medical interactions, and what they did was they tailored them by giving the patient the same name and changing the symptoms around to reflect essentially the same situation, but the same situation that unfolded in multiple different ways. So instead of headaches, they might have replaced that with dizziness, or something like that, something to make the data so it aligned within one particular case of symptoms. And so with this, when we actually look on the off diagonal, we see all this interesting structure. So the first thing I'll point out is this first little brief exchange here. And we call this an introductory stripe. So what you get is the patient talking early, and what you see is an echo all the way down through there, which means whatever the patient is saying there and explaining to the doctor early on is being repeated and addressed all the way through that communication, which we found to be actually a good thing. This is something that appears in a lot of good doctor-patient communications. Other things as well which are of interest are what we call engagement blocks, where you get these blocks of dense colour that are connected on the diagonal. And these are exchanges where they're on the same topic and repeating it to each other for some little block of time. What's interesting though is when you actually look further in time forward from that, is you don't get any repetition, which means that would indicate that whatever they talked about there, they closed it off. In actual fact, when you look at the text there, you find they're talking about drinking. And so he was talking about, do you drink alcohol? Found out that's not really related to the problem, and so stopped talking about it. And so they never go back to that concept, which is important. You need to be able to, as a doctor, they need to be able to locate, find out information and figure out what actually relates to the global diagnosis and what needs to be forgotten about. So then you have a summary stripe as well. So this summary stripe here at the end is by the doctor, because you can see the blue there, and actually shows that at the end of the consultation, the doctor summarises everything that's happened before that and comes to some kind of conclusive diagnosis. So these are the kinds of features we're looking for then, and we found this across the entire corpus of transcripts we had, and these features came out in most of the good ones and didn't necessarily appear in the poor examples. So we knew that these are the kinds of things to look for. Another feature is we can actually add these themes down the side. So rather than just looking at an abstract bunch of blue and red squares, you can actually get all these themes running down the side as well, and those themes can tell you kind of the topics that they're talking about as you move through the transcript. So our training consultations, as I said, we found things like the actual, this introductory stripe, the summarization. Here you actually have a couple of them. So the doctor gives a diagnosis, there's a bit of exchange, and then offers another diagnosis as well. So these are some of the things we see with those, which are indicative of good exchange. For the poor examples, where we have poor rapport building and poor task focus, we find that we don't get the patient speaking early, we get the doctor speaking early. And the doctor is the one setting the agenda, and so they're the one who actually is at the head of the introduction. And then we don't get a diagnosis stripe at the end. Right? What we do get though is people speaking at cross purposes. We call this a checkerboard. Right? So the doctor's repeating themselves, the patient's repeating themselves, and neither are actually repeating each other. And so they talk across each other. And so these are really, these visual features, you get very good at reading these plots. I don't expect much of the audience, you kind of look at this and it looks quite complicated, but like any visual technique, it takes time to build the visual literacy to make sense of it, and you can really start to pick out these features quickly once you get good at reading them. Alright, the last one from the training set, and then I'll quickly just show you some of the real clinical examples, was we actually filtered out some of the concepts. We found in some of the conversations they talked off topic, non-medical stuff. They were talking about sailing and boating and all this other stuff which wasn't related to the medical diagnosis, and so we actually got rid of that. And what we found was the one on the left is with all the concepts, the one on the right is filtered out to just leave the medically related concepts. We found that it took what looked like something with good, you've got your introductory stripe there, you've got your diagnosis, you've got all this other engagement, and turned into something which looks much more like the poor examples. So you can have a good chat, but if it's not related to medical stuff, it's not a good outcome for the patient. All right, so yeah, so we found that combinations of features are indicative of good and poor, and also interactive use. So being able to filter and do all this is really important in using the technique. So we need to leave the analyst in the loop to be able to click on it and use it to actually filter concepts and pick what they want to look at to be able to really use it. The clinical consultations, I won't spend too much time on these, but essentially after doing the training ones, we wanted to make sure it worked on actual real-world examples that hadn't been changed or modified in any way. We found that that was the case. So this was, this patient had rated this as a good exchange, and we found that that was actually pretty accurate. They elicit, after a bit of chat, they elicit their concerns, which are repeated. We get the introductory stride. We actually found, we got a diagnosis at about the 2/3 way through the consultation. And so when we actually clicked on that square, you can actually get the text by just clicking on the square. We found that was when the doctor offered the diagnosis. So they could have actually finished there, but they went on to have a bit of a chat past that point. And look, there's rapport building and such going on there, no doubt. So that's an interesting finding, is they don't always finish at the diagnosis. They can go on for some time afterwards. This one here, when I showed this plot to my colleague Bernadette, she said, I know exactly who that doctor is. I mean, she's got a corpus of hundreds of these, and she knew exactly which one it was, because this doctor is notorious for just repeating themselves all the way through the consultation. So she could tell, and you see that's what's happening. It's just the patient sitting there dumbfounded, I think, going, yeah, I guess. There's no real indication. If I was a doctor, I'd want them to actually repeat a concept or something back to indicate some comprehension. Instead, they're just kind of sitting there nodding their head, and it's all probably just going straight through to the back. Yeah, and the last one, I mean, this was another poor example. We didn't get much of an introductory stripe. You see a big absence from these initial turns. Strong repetition from the doctor at the end. Very limited engagement between the doctor and the patient, so that was another poor example. So just to summarise and finish, from this one particular study we found that the patterns do give visual clues of what's going on for further exploration. The presence of a feature doesn't necessarily indicate that it's automatically good or bad though. You have to, as an analyst, go in and figure out, okay, so they are talking to each other, but how are they doing that? Is it just blank repetition, or is it constructive engagement? You can't make that decision from a visual plot like that. You need to always go back in and use the tool to direct attention to where you need to go. All right, future work would be to incorporate things like pauses, timing, audio feeds. I've got a lot of fantastic information from you guys, thank you, about how to actually think about integrating audio and real audio into this, and using formats and things like that to maybe incorporate that aligned with the text to actually figure out, you know, if they're conceptually related, and also it's got the same kind of upward inflection on the vowel or something like that, then that might be some rich information we can bring to bear on it. So thank you for that. We could use alternative coding, so RIAS or any other kinds of coding schemes. We use the Lexomancer engine to do it at the moment, but there's nothing to say we couldn't use other conceptual coding algorithms. Metric analysis is something else that we've pulled out of this, and I'm happy to talk about that during the break. So more information, I'd ask just go to the website, discursis.com. Make sure it's an I, Discursis, because we looked for the other spelling of discursus, and that was already taken, so we're kind of left with the I version. So go there and find out some information, and there's the references listed on the website that you can check out. As I was saying, the PLOS ONE paper is probably the best one to check out if you want to find some more information. But I'll welcome any questions you might have.
Thank you, Daniel. We have room for a quick question or two.
How does Discursis identify the concepts in the first place?
Yeah, so what it does is it uses basic corpus statistics. So what it does, it takes the transcript itself, or any text that you put into it, and it generates statistics based on that of word frequency, co-occurrence, how words are kind of travelling together through the text to build concepts. So if I was to say to the room, complete this sentence, United States of, you would all say, or think America, wouldn't you? Right? And this idea, I mean, you're all linguists, right? You understand these principles of how words keep company. And so that's what Lexomancer uses, an algorithm like that, to actually build concepts from the text itself, rather than using an external ontology. because it's important, particularly with conversation. There's a lot of localised contextual information there, and things are used in a very particular way, and so we build it off the text itself. And then what we do is, once we've got those concepts identified, is we tag each term with what concepts are appearing there, given the evidence of the text in that utterance, and then work out a similarity based on that.
So a concept is a statistically defined keyword in this
Yeah,
case?
yeah, absolutely.
Any other questions?
Yeah, go. Yeah.
Another question. How do you get access to these medical records? So, in the NHS, the data governance rule means that I, as a computer scientist, I'm not allowed to see doctor-patient.
I've got a lot of charm, and so no, I'm like, you know, Tom Cruise. I kind of fly in through the top of the database and grab all the information. No, we've worked very hard to establish contacts within the social science community. I mean, myself, I've got half of my appointment now is with the School of Journalism and Communication, even though I'm an engineer and a computer scientist by background. And we've worked very hard to establish collaborations with people who are data collectors. And so we're the tool builders, and we make alignments with people who are the ones who have the data already and want to make, you know, other sense of it. So yeah, we've got data on the doctor-patient stuff from them, from studies they've done. We've got autism data from people and colleagues over at UCSD. We've got dementia data from colleagues at UQ as well. Autism, sorry, I've already mentioned autism. Yeah, multiple different data sets we collect through collaborations.
So you're not getting them directly from your streaming from the NHS, we're getting them from other researchers who have already got through the
established linkages with those particular government organisations. Yeah. So Queensland Health, for example, they've got, you know, researchers within the organisation who we're good friends with, and they're strongly associated with the University of Queensland because we've got one of the largest medical schools in that part of the country. So, you know, there's a strong kind of sense of collegiality there, and so, you know, when they do find their way into the Queensland medical system, they're always got open doors for researchers to come in and work with them on particular projects. So, yeah. But no, I do understand. It's very, very difficult as a computer scientist to get data. Yeah, very, very difficult.
Thank you.